just, and what I try to do is use like what happens in your daily life to kind of make sense on the test. I think, well, you know what you're doing is putting those terms to it that makes it ring on the test. So when it looks at like family therapy with this one, so the Murray Bowen intergenerational approach would take looking at grandmother, kind of looking at the role grandmother plays in their life, and kind of looking at those repeated patterns and helping mother realize that we're repeating those patterns. Okay. We talk about the authoritarian style parent. The mom is very just, she's setting the thumb down, her head down on, their thumb on the kids' heads and do this, do this, do that. Could it be an issue with needs? Is that a Maslow issue? If she doesn't pay the car payment, will the kids not have food, clothing, water? Joyce? Or anybody? Could that be a Maslow hierarchy of needs issue?
No, she's able to have the food and those things in the home.
Mm-hmm. I think, and I'm not trying to, I'm just using the family to help understand the terminology.
Okay.
Okay. So, if that's because, if I had, well, I do have 2 car payments, but if I had a lot more than 2 car payments, some money would have to come from somewhere else.
Mm-hmm.
So that would be a hierarchy of needs for me. It'd be like, okay, I'm not angry. I hear that you need grades, but if I don't pay these car payments, then our family's going to suffer at a lower level. So that would be a Maslow theory.
Okay.
Okay. Okay. And then if we took like a structured approach theory, then that family he would look at setting up the structure in the home. Maybe we've got some role reversal, maybe kid is not being able to be a kid yet. And kid also doesn't understand probably that you can't just take back a car.
He doesn't understand that.
Yeah, because he's not supposed to, because he's a kid. He's not supposed to. Thank you for sharing, and I hope that it helps that we kind of put it into like some of the terminology of what's happening in your life as opposed to help you as you see it on the test. Okay. Somebody else share something with me. Thank you, Joyce. I really appreciate it.
Yes, ma'am.
Mine is not as interesting as Joyce's, but I had an individual who I was providing an intake for, and it was just a comment that he had made. I kind of chuckle back at it, but he was struggling with some depression. I happen to think with some of his statements that he was making, he was a little delusional, maybe. He was indicating that he was kicked out of the home where he was living at, and the home belonged to his girlfriend and her boyfriend. So that was a little interesting, and I asked him to elaborate. He was very circumstantial. I mean, he kind of just provided a lot of information for every single question that I've asked, that I asked, and he kind of was just all over the place. So initially he came in wanting Seroquel. So he's going to be, seeing our provider for that. So it was just interesting. He wants it, yes, he says it's to sleep. And he says, when I asked him about any hallucinations, he says sometimes, but he was very guarded. It was a little difficult for me to be, for him to elaborate, just because he didn't want to. So he kind of was holding back a lot of information. So
what would be the best assessment to use with someone like that? MSE, mental status exam.
I gave him a little bit of a mental status exam, absolutely. And he did great with it. So it was just like a mini mental, a couple questions, but he did okay with that. So that's, I still found his intake a little difficult. I was not sure what diagnosis to give him, but then I started asking him about his mood, and he indicated that there are times where he was elevated in his mood, and then he would come back down, go into a depression, and then he started coming out saying he has a history of bipolar, and so that's towards the end he wanted to open up, but he was still a little guarded. So yeah, so I'll be seeing him for therapy in a couple weeks. Yeah.
And my first thought, again, just because, again, not the real world with the test, so that'd be a typical question for when to give an MSE, the mental status exam. someone who comes in who is just kind of doing that initial intake. And usually MSE is not initially used in the initial assessment. It would be used in like the emergency room, or we've got a client who comes in under crisis. So that's checking his orientation. And you said guarded, and the words like disheveled. You talked about tangents, talking in tangents, that tangential thoughts.
Yes.
Those are all things that are part of an MSE. So those are words that you'd see on the test about an MSE.
Okay.
And when you said cerebral, my first thought was bipolar, because I wonder if he was in a high episode and he needed to sleep.
Right.
And that was
right.
just again not so. When you hear when you read vignettes or you hear things like that, so for the test, you automatically should kind of go like, okay, I'm going there, and it may not be the best answer, but at least you know where you're headed.
Right.
Just based on your knowledge and kind of where you're going.
Right. Yeah. And he indicated, I mean, he says that he sleeps, some nights he sleeps pretty good. And then other nights he's up for like 24, 48 hours. So.
Okay. So I used to call it the baby bipolar, and one of my students said, no, babies get it. So what's the minor, the not quite bipolar? What's that diagnosis? Anybody?
What's the minor bipolar, you said?
That's not that your highs and lows, your highs are not as high and your lows are not as low. That's cyclothymia.
Oh, that's interesting. Okay.
So cyclothymia. Okay, manic depression is bipolar disorder, but cyclothymia is, if I say baby bipolar, will that freak you out? I've always used that term, and the student said, babies get it? No, it's just a minor version, a smaller version of bipolar. So your highs are not as high and your lows are not as lows. So it's I'll pull it up for you. It's cyclothymia. It's a pretty good image I like. So if you see that, so bipolar 1 has more mania, okay, and then less depressive episodes. And then, oh no, thank you. You were good, Danielle. I appreciate it. Okay, so then my bipolar 2, see, I get more depressive, and cyclothymia, that is just a lesser version. So my highs are not as high and my lows are not as low. Okay. Can't see my screen. Let's see here. I'm not sharing. That's probably why. There we go. Better? Perfect. Okay. So yes, see my bipolar disorder? Okay. So then my bipolar 1s, I've got my really high manic episodes, hypomania, and then my cyclothymia, I don't get as high. So we used to have a term called dysthymia. We took that one out of the DSM. Dysthymia used to be a minor form of, major depression, and cyclothymia was a minor form of bipolar. Okay. So cyclothymia, baby bipolar, not for babies, just okay. And while we're on the subject of bipolar, so what is the medication of choice for bipolar? You can type it or you can speak it. Yes, it is lithium. And what do I know about lithium in blood work?
You need routine checkups, right?
You do.
I think it affects, is it the liver or the kidney? I can't remember which one.
All the above.
Oh, both. Okay. Okay.
So a question on the test might be which medication requires, and it's usually monthly blood work. That is on lithium. Lithium is the one that requires that blood work. Okay. So on your bipolar disorder and your major depressive scale, we can have then we can have highs and lows. The highs and the lows can actually also cause sometimes some hallucinations, delusions on both ends of that. So if I've been up for a couple of days, I can hallucinate, or if I've been so lethargic I can't go out of bed, I might have some hallucinations at the bottom there. So the differential diagnosis is between then a bipolar disorder with psychotic features or a schizoaffective disorder or schizoaffective. And my schizoaffective disorder then is my people who have the schizophrenia with the affective disorder. Okay. And I'm not, I did lesson today on helping relationships, but just some DSM stuff while we're there. Okay, so that's schizoaffective disorder. And then schizophreniform, that's one that is the, excuse me, if I can have a not quite diagnosis of schizophrenia, so that's a time one. So schizophreniform is one that's based on time. Schizophreniform. Okay, so I like that one. Schizophreniform, it's meets the criteria for schizophrenia, but less than 6 months. Okay, so it can be, once it becomes longer than 6 months, we look at it being full-blown schizophrenia. And then a brief psychotic disorder is from 1 day to 1 month. Okay, so 1 day to 1 month would be a brief psychotic disorder. If it lasts more than 1 month and meets all the diagnoses, I'm probably talking about a schizophreniform, and then next I'm talking about a full-blown schizophrenia.
Is it uncommon for children to be, and I don't want to get too much off topic because I know it's not the group, but is it uncommon for children to be diagnosed with schizophrenia?
So the diagnosis, the age we most often see it is between the ages of 16 and 21, and actually you have to be diagnosed by the age of 19. So what most often happens, and yes, there are cases, and I mean we've seen it on TV. There are very rare cases, especially kids who have been set some trauma. We do see it. It's rare though. So what we're looking for is a kid who's like 15, 16, 17 goes through some crisis, some trauma, and then we have our faux psychotic break. So there's a genetic piece as well as an environmental piece. What the most common ones I've seen are kids go off to college. So I get parents, my kid was just fine. He comes back to college, he goes off to college, he comes back and he's had a full-blown schizophrenic attack. But you do have to be diagnosed before the age of 19. Okay, we think it's some underlying predetermining stuff, and then suddenly you have the trauma or the stress or all those things of starting college or the things that happen in 18, 19, 20 that really kind of trigger it. Okay, and the folie à deux, I've never seen this in real life. I've heard about it, and when two people have the same similar delusion. So I've seen it with drugs, not gonna lie, you both get high and you've seen some stuff there, but I've not seen it in the real world. But it's supposed to be, again, when people have a shared psychotic disorder, they see the same hallucinations, they share the same things. Okay. Difference between hallucinations and delusions? Anyone? A delusion is a thought, absolutely right. Okay. So if you've spent a little time with me at all, I will tell you that I am totally in love with Barack Obama. I just am. And not because he was president. I was in love with him before. He was a community organizer. He really tried to change the things of Chicago. So I love him. So in my mind, in my very delusional mind, Barack Obama is in love with me. He is waiting. He's going to leave Michelle and the girls. He's going to come live with me in my house. We're going to live happily ever after. That is my delusion. Okay. It is my and it can be a idea of reference. An idea of reference means I had a little bitty piece of it, like because when he came to Chattanooga to visit, in my mind, he came just to visit me. So I had an idea of reference, and I take that little bitty idea and I make it this huge thing that yes, he's in love with me. So that is definitely my delusion. So my hallucination is if I ask you, do you see Barack sitting beside me? Okay, so that is my hallucination. So hallucinations are visual, tactile, see, hear, and feel things. Okay, and I've also heard of olfactory hallucinations, where people swear they taste things. So when I open the group one day and I'll say, don't you see Barack sitting beside me, or Barack is rubbing my back, then you know I'm having a psychotic episode. However, until then, I'll live in my delusions. Oh, thank you, Danielle. So wait a minute, I don't know. Those are fighting words, because that's my man. So but yeah, so that is my hallucination and my thing. So I do have to tell you, though, an idea of reference, and kind of a anecdotal. So I really have shared with most people in my life my deep-seated feelings for Barack Obama, and I shared that with a client. This has probably been 10 years ago, and I would always make a joke that let me turn the camera back on me for a minute. I always made a joke that the CIA was listening to my phone, because how much I love Barack. I talk about Barack all the time. The CIA is probably tapping my phone, and they may be, may not be, but it was just kind of in a joking situation with a client that was reasonably stable. About 2 or 3 years after that, I got a call from the local mental health facility. So it was under the Tarasoff Act, which means, anybody? Tarasoff Act, duty to warn. Got it. I got a call, and I had a duty to warn. My client, my former client, was having a full psychotic episode. He stopped taking his medication, and he was very sure that he was trying to break out of the hospital to come and protect me, because he believed that the CIA had implanted some things in his head, and they were tracking his thoughts, and they were after me. Because I had these thoughts about, Barack Obama. So he was coming out to come out and save me. Okay, so that was one of my, so yes. So he had some ideas of reference, the duty to warn, and he was hospitalized without his consent. So he had stopped taking his medication. Okay. He was also actually on methadone as well. I've seen some of those medication questions. Medication questions. What is methadone? And what's it used for? It is for withdrawal from opiates. Okay, so it is prescription. It is still highly addictive, but it is less dangerous. Especially, we have a lot of moms who are still addicted to opioids. So it is a medically treated, medically assisted harm reduction method to drugs. You got it. So it is mainly used. Actually, we've seen it used with alcohol as well, but mainly used with opiates. So that would be my heroin and any of my pills, my Oxycontins, my hydros. All those are opiates in the opiate category. Okay. So any questions again as I go along? Feel free. And today is helping relationships. We're going to talk about some of these important people and go from there. And that was just some information on medication. Anybody else have anything you want to share? Certainly, again, I love living vicariously through my students. That's what makes my job so exciting. Danielle, anything exciting happened to you this week or this month? A bizarre client?
I think life is just bizarre when you're in this work, huh? And so I love every bit of it. So and people always ask me, are you diagnosing me? I don't care if I'm at a Bible study or a tea or a lunch. And I say there's one sure way to know if I'm diagnosing you. And it's if I have your insurance information and copay.
I haven't used that one. I like that. Thank you. Thank you. I've gotten to the point where I sometimes just don't tell people what I do, especially like a nail tech or a hairdresser. Just no. And at this point, I can just say I'm a college professor, which makes it easier, I just don't want to hear it. No, like, no. So, but that's cute. I'll remember that one.
But I'm glad that you guys agree that the bizarre sort of comes for us.
Oh, I think we're drawn to it. We're in this profession for a reason.
It's the best law of attraction. It's both ways.
Okay, so yeah, we we didn't choose this profession to work with, the families with 2.5 children in the white with a white picket fence. Well, we did, because many of those have issues too, but we're drawn to the crazy. Okay. Okie dokie. So again, I'm gonna go back to sharing my screen, and feel free to ask any questions. It's still recording, and let's see here. So I'm going to share my screen. I'll tell you one other thing. You're never a king in your own kingdom. I don't care how much you know in your own kingdom, but I think you're an idiot. So I always say, well, research says, as opposed to. Okay, so counseling and helping relationships. One of the things that's the most important, and I've seen on the test a couple of times, is, and it just in fact in life, that the most important event is the therapeutic relationship. You can have all the skills ever. You can be the best Rogerian. You can be the best Gestalt. You can be the best at whatever you do. However, the relationship is what matters. And so all of us bring something very different to the table. So no matter what your skills are, your skills will not still come across the same way as mine or Danielle's or Maritz's or anybody else's, because you bring who you are to the table. Okay, so the first one we'll talk about is Carl Rogers, and he was person-centered behavior. And what he really believed is that the clients really had what they needed, and all our job was to kind of hone in on that and give them the support they needed. So most often the questions that you'll see, if it's Carl Rogers or client-centered, person-centered, those are used interchangeably for the test, are empathy, genuineness, concreteness, respect. I see non-judgmental attitude, warmth, be yourself, be who you are, be warm, be empathetic. Empathetic is putting yourself in that person's shoes while they made that decision. Okay, and I know you all know, but that's so much different than sympathetic. So empathetic is when a client is standing in front of me and she tells me how she left her babies in the car to die when she was going to get meth. In her mind at that time, that made the best choice to her. That seemed like to be the best choice. So that's empathetic. When she was I can put myself in her shoes and understand. Okay, it doesn't make it right, and certainly it doesn't, change anything else, but I can at least empathy. I can empathize with why she made that choice. Okay, so genuineness. We see the word congruence. Congruence is when everything lines up with what I'm saying, my body language, everything is coming across the same way. Incongruent is definitely when I'm sitting there with my arms folded and going, yeah, we're fine. Incongruent is when you're in a relationship and you tell your partner, yeah, I'm good with you, I forgive you, and you're rolling your eyes. So those are incongruent statements. And what our clients did, according to Carl Rogers, was to be very congruent. Okay. So he talked about therapy is contradictory statements, nonverbal cues, and exhibits defensiveness. The therapist is superficially professional but likes genuineness. These are some of the concerns. The levels of how you get to be that wonderful person-centered approach. So what we want to do is be open, honest, accurate, and genuine, and reflect the ideas and reactions to the client. Okay, but he really believed the client was the expert, as opposed to when we had Freudian, because Freud and all of his followers believed that the therapist was the expert. And how dare Carl Rogers come along and say, no, not true, not true. Okay, just some terms that you'll see. Probably seen these before. Restatement. So when you clarify what he said, make sure that you understand. Reflection, reflect back. Paraphrasing. You all went through college, you know how to paraphrase so you don't get in trouble for plagiarism. So paraphrase, and summarizing at the end. So at the end of the session, I might say, so Johnny, this is what we worked on today. You shared with me that you have some concerns about your children, and we've agreed that this is the current treatment plan. So I'm going to summarize at the end of the session kind of what we went back over. Okay. Many times when we talks about reflection, so restatement of what the counselor heard, emphasizing any understanding emotional content. So I'm reflecting back some feelings. So many times my clients don't have the feelings that it goes on along with those words. So reflection will be, okay, Johnny, so you shared with me that, you know, you're struggling in school. I would imagine this is difficulty and may cause you to be sad. Sometimes I'm feeling in the missing emotional piece when I'm reflecting. Okay. Silence is okay. Now, most neither the client nor the counselor speaking can be used for reflection. This is not on the test, but just a word of wisdom when you're doing counseling. When a client drops a bomb, silence is that's not the best time to use silence. Okay. A client says, if I drop a bomb, you know, something, you know, that you didn't expect, something I just shared with you, you know, oh, by the way, you know, when I was 3, I was molested by my father. That's a bomb. Silence is not the best time to be used there. Okay, they just dropped a bomb. If you're not sure what to say, at least acknowledge that they shared it. You know, thank you very much for sharing. That must have been very hard for you, etc. Especially when you're not expecting the bomb. I think you've probably all been there. You've been in practice long enough to know, like, oh, didn't expect that. Silence there is just not okay. Okay. Confrontation. Most of the questions don't talk about confront. We don't do a lot of confrontation as counselors in general. However, when a client is in a session that you have, they've repeatedly told you something differently. I'm done with men. I'm going to stop sleeping around. I'm going to do this. And the behavior continues. Then that answer would be confront. Well, Barbara, you said last week that you would not do this. Okay. So that is a great technique in group. You'll see a lot about that in group and also in substance abuse. Okay. So we're calling people on their stuff. Okay. Structure. Used to set goals and agreed to counseling. That's how the counseling session works. We're going to set those important boundaries and goals. Okay. You know, we use the World Health Organization now. That is what we use for that. So the GAF, that's where that comes from. And then I will send you this. So as before, we will go over this briefly, and then we'll spend the rest of the time just going over questions based on that, based on our relationships. Okay. Motivation for counseling. One of the questions is, what is the main reason people come for counseling? Guesses? Loss. What else? Fear, anxiety. Those are good ones. Worries. You got it. So on the test, it'll say, you know, there's a list of things of why people most often come, and the answer is self-disclosure. So that pretty much talks about all of what you've talked about. So they've got some things they've just been dying to tell somebody. So whether it's something that's recent or something that happens a long time ago, or, you know, my mother just died and I can't get out of bed. So it's self-disclosure is the.
So it wouldn't matter, like the reason they're coming here is for grief. It's kind of just simple, like self-disclosure. Okay.
So my grief is because my grief is so overwhelming. I've got to talk to someone about it. Okay, I've got to share some things with you. I can't, and grief in general, I'm not coming to you because I feel sad. I'm coming to you because I can't get out of bed. I'm coming to you because, you know, I feel like I'm abnormal because, you know, it's been 6 months and all I can do is still think about him. Okay, so even if it's normal grief, there's something about what's going on they feel like they really can't share with their surrounding, the people in their circle. Okay, so it's self-disclosure. So again, it could be grief, it could be the anxiety, it could be, you know, I'm OCD and I have to count, you know, 7 steps before I can do things. It's about self-disclosure, something I haven't been able to really share with anybody else yet. Or so they've shared with someone else and they think, girl, you should get some counseling. But self-disclosure is what we're coming for the test at least. Okay. Talk about empathy. You know what coping skills are? Coping skills enable an individual to manage stressful situations, problem solving, handle uncertainty, and develop resilience. Okay, we all have coping skills. Some are better than others. Drug, alcohol use is a coping skill. So hopefully that our clients have gotten past that. However, if not, that's their coping skill, and we teach them new coping skills. Of course, cultural awareness, that's a huge part. And I'm hearing there are more and more questions just on the importance of cultural awareness. And I just think that's kind of where we are at in society these days, is making sure that we see color, that we remember the term salad bowl, that every culture is different. We do not use universality when it comes to treatment. Universality. We don't do that. Everybody gets their own, not their own, but universality implies that I will treat you like I've treated everybody else, and that is not what we do. The fact that you are an Asian or of Asian descent, and you bring different things to the table than some of my African American clients do, or you're an Asian male, and there's lots of you have lots on your shoulders. The family is expecting you to do all these certain things. So I've got to make sure that I understand the importance of culture. So cultural awareness, race, ethnicity, sexual orientation, socioeconomic status, religion, and age. All of those things. Okay. Rapport building, relationship building, initial stage, initiation. I'm going to clarify, structure, and then the relationship phase. So that's what it looks like when we're kind of at relationship building. Okay, again, so that I just got to know you, come in my office, I'm doing this assessment, my initiation, that's my orientation phase. I'm introducing, this is an introduction to the counseling process, which sets the stage for what's going to happen. So, hi, Johnny, come on in today. I really appreciate you being here today. I'm sorry for what you're going through. So let's talk about, what's going to happen in counseling, and talk about what the process looks like, and orientation, all that good stuff. Okay. Then clarification. That's where we're going to talk about the problems, the goal setting. Johnny, I'm really sorry that you lost your job last week, and that you feel like your wife's about to leave you. So clarification. It sounds like to me that your concern is that you'll never find a job. Your concern is, your wife doesn't love you. Whatever your concern is. Then structure. Okay, that's where we're going to look at what would come in the structure phase. What would I do with that?
Is that your rule building, or you're setting your rules and stuff?
Yeah, exactly. Goals, treatment plans. Exactly. So what are we going to do? So what happens next? How do we fix this? Okay. And of course, you all know that, I can't just give Johnny goals and say, Johnny, this is what you'll do. That's something we work out together. And then the relationship phase. We develop a relationship, and we'll work toward a mutually agreed upon goals. Okay. And then positive interactions, those steps, exploration of feelings. Counsel will use rapport building skills, defining the structure. On the questions when it comes to ethnically diverse cultural questions. So when you have a client who is of the minority, and when you're reading the question, you need to assume that you are the majority. Okay. So if you're the majority population and you have a client who comes in who is of the minority population, one of the questions is about sharing information. So according to the test, it is more important to share more of your stuff and your personal stuff, and not details, but more of your personal life with a client who is of a different culture. Somehow that helps to increase rapport. So you might want to share that, yes, I've been in counseling. I've been a counselor for 20 something years. I've done this forever. I am a specialty in these kind of areas. So on the test, that question talks about, so if a client who is of a different race than the therapist, assuming the therapist is of the majority group, the question is then, yes, so that the people of culture, you would share more with them of people of a different culture. Okay. I mean, that's debatable. I'm not sure that you want to agree with that, but that is just the answer for the test. Consolidation, planning, and then termination. So those are our tests, our task. We talked about silence. It's an effective tool, but used carefully. Okay, transference. I saw a question, I guess I was tutoring last week, and one of the questions was, how did Freud see transference? In the beginning, he thought it was in the way. He thought transference was like, ugh, just this extra stuff that was in the way. Now we know that it's extra stuff, but it's not in the way. It's either good or bad. It just is what it is. So countertransference and countertransference and transference are sometimes called that extra feeling, the extra thing that's brought into counseling. Okay. Any comments on that? Anyone, any different on transference or countertransference? Okay. And if I've shared my story with you already, I'll share again. So one of the way it looks like sometimes is I did have I've always done consultation. So I was doing an in-home consultation with the case. And the person, it was right before Thanksgiving. And there was a little black boy, and he was probably 12 or 13. And of course it was before the holidays, and his uncles and aunts and everybody was, let me back up. So the reason I got the case is because the first time the person went out was there were 4 black men sitting outside under the tree, and she felt threatened. She was afraid to get out of the car. It was a person who was not black. So then I got a call to ask me if I would take the case. And I'm like, sure, no big deal. 4 black men under the tree just reminds me of my family. That's what happens, Sunday afternoons, all my uncles and cousins, everybody would kind of come over and hang out, at my grandma's house. That is, for me, very culturally appropriate. So even before I went to the house, I kind of had my own thoughts in my head. And I was seeing them around Thanksgiving, and going around Thanksgiving, the grandmother was, she was cleaning chitlins. So if you're not of African American or Southern descent, she was cleaning chitlins. Those are the intestines of the pig. My papa, we grew the hogs, and we did that. So it was like, whoa, it felt so good. It just felt so good in this house. And that was definitely my own countertransference. It reminded me of my childhood stuff. And even then, knowing that this would happen again at Christmas, I very much wanted to keep the family until Christmas, even though the kid didn't need to be there, but that was my own countertransference. It just felt so good to be in that house. And for me, I can't understand how the client, the previous counselor, didn't want it. Like, how would you not want this case? So that's what it looks like. It's neither good nor bad, just making sure that we don't let that interfere with what. I mean, if I kept seeing that client to the next holiday, because, Easter was coming up and I'm sure she was going to cook a ham, all of those things, once I became aware of my transference, and I knew that I had to set goals and that's kind of things, that's what it looks like in real life. Anybody had some other issues you want to share with transference? What it actually feels like or looks like? Or countertransference, that was in my case at least. None of you have had in your childhood stuff brought in with your clients? Joyce? Maritza, never? Okay, well, stick around. It'll happen. It'll happen. And Freud will say it's unconscious, and many times you're not aware of it. You just know that it feels good. In the middle of it, I didn't know why I wanted to go back, but for most often, it feels good. Or it may feel bad. You may have someone who reminds you of your mother or a boyfriend or someone that you didn't like. You're thinking, oh, what's going on there? Okay. Attending just means being there. You're you're right there with the client. You are attending. You're making eye contact. You are in the session. A term we use now is like mindfulness. That you are enjoying this moment right there with that client. And of course, that's very, very important. Resistance. We all know what that is. Sometimes clients are resistance. They don't want to. They want to change, but they're terrified of the change. They tend to be resistant. When it comes to the issues of culture, We have to be very careful that that doesn't look like resistance when many times it's a cultural issue. I think we may have talked last week about CP time, color people time, that sometimes time is different when you are not of the European background. Sometimes time is different. So what I hear often is a client who is a Hispanic, Black or brown, someone who comes late to therapy often, and someone will say that they're resistance, they're in resistance. So be careful. We know that that's not a cultural difference, that it really is just resistance. Okay, resistance can be obvious, such as counseling or delaying appointments, not following through, or not fully engaged in the process. Okay, which is what it looks like. However, we take that cultural information that we now know to make sure that we're not just, oh my gosh, they're a half hour late. So many times, if you run on a different time, it's not resistance. It's just that we don't always see time the same way. Talked about reflecting. Errors. Reflecting is one of several active listening rapport buildings, should not be overused. It is essential that the counselor be able to offer meaningful statements, but not simply repeat back what is said. And one of the things is a client will often tell you, it sounds like you're feeling sad. No, I'm not sad. I'm mad he's gone. So it's really okay that we use that reflecting technique, and the client can then kind of clarify what he really means, or he or she really means. Okay. Do we give advice? Yes, no? I don't see any typing going there. Maybe? I got a yes. So there's two types of advice, substantive and process, okay? Process is more empowering and helping clients navigate based on their own solutions, okay? And substantive advice would be telling the client he or she should practice deep breathing. Okay, so substantive is what I'm going to kind of give you advice on. You know what, when the next time that you are in a panic attack, why don't you try this? Why don't you try that? Okay, with caution, exactly. Okay. Let's talk about these. These are a couple of things that are on the test recently when it talks about crisis. You guys informed, are you guys familiar with trauma-informed therapy? Trauma-informed, yeah. Yeah, okay, very good, very good. Okay, so just in general, phase one, the first phase consists of the initial threat or event, which causes a crisis. The second phase is escalation. The initial attempt to manage the crisis is ineffective and it begins to escalate. The third phase is an acute crisis stage, and the fourth phase is the climax. It comes down. So it goes up, up, up. That's your crisis period, and then it comes down. Okay. However, when it comes to treating that, this is a crisis intervention method that we use. And this is a little different than most times of how we are used to doing crisis as a therapist. I think I've shown you the triangle before. Yeah. Go this way. Okay. So that really is that crisis intervention model. And to make sure that you know that, because it's a different from most of us and we've used to doing. So when it comes to the crisis intervention, this actually came around after 9/11, and we had all those lovely school shootings and things like that now. So the first thing you do is you assess lethality. Okay, so I've got a crisis. I've got someone who's school shooting, someone who just shot themselves, someone who's gone through any kind of crisis. The first thing you do is you plan and conduct a biopsychological assessment, including the lethality measures. Okay, So I've got people who've running out of a burning building or a bomb situation going on, and there are 20 people in the room. We're all trying to get them going. So the first thing I'm going to do is just plan and conduct crisis biopsychological assessment. That's a brief one. I'm not spending, all these hours doing that. I'm just kind of what's going on, and trying to make sure that the lethality is no longer an issue. The second step is establish rapport. It has to be established quickly because the people are going through a crisis. So I'm going to do everything I can to say, hey, I'm Pam Turner. I've got some training in crisis intervention. I'm here to help you out. Just trust me, it'll be okay. All those wonderful things we say in rapport. Step 3 is identify the dimensions of the presenting problem, or maybe if there's a last straw in that. What most of my peers, my clients also, it's step 4. We do not get to explore step feelings until step 4, which is unusual for most of us in this field. Okay, and then step 5 and 6, and the goal, of course, again, is to get them back to where they were before this happened. So that's what that says. Okay, so those are Robert's 7 stages. Conduct the thorough biosocial assessment, make contact and quickly establish rapport, identify the specific problem, provide counseling, and attempt to understand the emotional process. But again, not until number 4 do we actually kind of look at their emotions. Okay, so that talks about CISD. Okay, so that's critical incident stress debriefing, and that's another structured term of crisis management. Welfare support, grief in general. Can someone tell me Kubler-Ross, her stages of death, dying, and grieving in the correct order? Type me some letters in there, or tell me, someone can mute in. What are those? What are her stages? DABDA, yes, very good. Denial, anger, bargaining, depression, and acceptance. Exactly. And what she said was that everybody gets to acceptance at one point, and they go through different stages at different times. Some may take longer than others. Some may be in depression one day. Some may be acceptance in the next 5 minutes. But according to her, we all go through those, all in different order. Again, just an FYI. So that is currently the correct answer for the test. However, new research is indicating that not everyone gets to acceptance. She said that forever and forever, and we've bought that. Now we do have new research that some people die without ever getting to acceptance. So DABDA, if you don't have that. Denial, anger, bargaining, depression, and acceptance. DABDA. Okay. Has anyone been with a client or experienced a loss where you've seen the person never got to acceptance?
When I worked at a behavioral health hospital, it was a different behavioral health hospital about 2 years ago. I had met a lady who had came in. She was obviously sent in. She was admitted to our hospital, and she was Spanish speaking. Obviously, I'm Spanish speaking, and the doctor, was like, I tried using the translation line. I couldn't figure out, what's going on. Can you meet with her? And I was like, sure. And what ended up happening is she was feeling suicidal, and she was having hallucinations, but nobody knew what was going on. And so I talked to her. What ended up happening is she had a daughter who was married to this guy, and she had a 2-year-old son. And the husband ended up stabbing her daughter in front of the 2-year-old. And the mom, which is that current patient, she ended up not going to the funeral, to her daughter's funeral. And when I asked her why, and she said, because I couldn't accept that my daughter was gone. I didn't want to believe it. Mm-hmm. And so at that time when I had seen her, it had been 11 years since her daughter was killed. And so it had been that long that this lady had not accepted that her daughter was gone. And so she said she started having hallucinations, saying that, I hear my daughter telling me, just kill yourself and come with me, so she was having command hallucinations as well. So it was just really sad. And I mean, I got a little emotional, so I had to, kind of collect myself as well. But I got a little emotional just her telling me the story. And she now had custody of the grandchild. And the whole overall situation was just really sad.
It sounds like it. That sounds really sad.
Yeah.
And just that, and even without the psychotic piece that we now believe that some people just never get to acceptance. So yeah, we have people on their dying bed who are just so sure they're going to not die. So yeah, we have if it's not on the test yet, I would imagine that's kind of newer research. It'll get there. But yeah, thanks for sharing that. I really appreciate that. Okay. Let's see here. Let's get let's go set some terms to make sure we got, Maslow's hierarchy of needs. We talk about congruence. Touch. There's some controversy of the touch in counseling relationships. Studies have found that touch, such as a pat on the shoulder, hug, can be beneficial to some clients. Touch can provide comfort, reassurance, grounding, and some support. However, there's an argument in touch violates personal boundaries and can be considered unethical. Touch is always interpreted in widely different across the United States. Okay, so tell me kind of where you're at, what you were taught, what are your beliefs on touch? And appropriate touch is where I'm going. Joyce, what are your beliefs on touch? What were you taught?
I was taught that my family, we're very affectionate. We hug, but I was taught that I have to be careful with hugging because some can interpret that as the wrong way.
Mm-hmm.
But what I do now, I'll shake their hands or I try. I don't want to offend anyone if I don't, because I'm a hugger, but I come in contact with individual or clients that are huggers also, but I hug a certain way, like to the side.
Yeah, side hug.
Yeah, side hug. Yeah.
Uh-huh.
And they're okay with that. But here again, you have some that just grab, and I guess it's want to be just appreciative that I have someone that I can talk to, that I'm not being judged, but still, I have to be careful with that myself, because I don't want to get caught up as like the teenager. I don't hug teenagers, boys. I just don't want to, because they're going through there, and I don't want to be a part of that.
I can ask you, how old are you? How old are you?
I'm 53.
Okay.
But I don't look 53.
I bet you don't. So. But that's what I was wondering, because sometimes it's that if it's a motherly figure or as opposed to someone that they could be sexually attracted to. So that's where I was going with that. Yeah.
Because my clients, he will, if something's going on, he will not respond to another worker, but he will respond to me. So I have to be really careful with that, because I'm the counselor, the therapist, your worker. I don't want this client to look at I'm your friend, because we're not friends, but I guess it's being comfortable, trust that he can trust. I'm going to tell him the right thing that he has to do. But here again, you can easily get caught up and you don't know what that person is thinking.
Yeah, and that's your responsibility as a therapist to make sure that you make sure it's a very safe space.
Yes.
Okay. So in general, though, it depends on, like I've said before, I lived in South Florida forever. I was taught don't touch, don't touch, don't touch. I move here, everyone touches everyone all the time. Like, so it really is kind of, first of all, with your agency, make sure you're following your agency rules. Okay. And then in general, we want to make sure that we are not being a detriment to our client. So I'm a touchy-feely with my family, but because it was so ingrained in me in school that you don't, so I find it difficult sometimes. And then I will, on the other hand, because I find it difficult sometimes, that especially in the South, and my clients think, oh, why aren't you touching me? Because culturally, this is what happens here. So that's kind of a very careful. You know, the Code of Ethics just says make sure that's not detrimental to the client. Okay. Okay. Okie dokie. So, number one, just chime in A, B, C, or D. Symptoms of professional burnout consist of fatigue, headache, insomnia, depression, anxiety, or boredom, among others. When does burnout in counselors and helping professions occur? A, when countertransference is not managed. B, when counselors become desensitive to client issues. C, when counselors are overworked. Or D, when the client regularly cancels or don't show. When does burnout occur? Let me see some letters in my box there. A, B, C, or D? I see a C, I see a C. And correct, the answer is C. You got it. Number two, Robert Kirchhoff wrote Toward Effective Counseling and Psychotherapy, a book wherein he discovered that therapeutic interventions did not always have a long-term positive impact on clients. Kirchhoff also created a 5-point empathy scale designed to measure what? A, the counselor's ability to accurately reflect. B, the effectiveness of counselor. D, defensiveness of the counselor. Or D, adequate structuring of sessions. A, B, C, or D. That's number two. He wrote Toward Effective Counseling and Psychotherapy. I see a couple of A's. I see a B. The answer number two is B, the effectiveness of the counselor. Okay. And Coffin's scale measured the degree to which a counselor was providing empathy, genuineness, concreteness, and respect. B. Okay. Number three. Okay. Reflection is a practice where counselors acknowledge the meaning behind the client's words. What do counselors use? Why do counselors use reflection in sessions? A, to help clients understand underlying emotions. B, to provide assistance. C, to grasp goals for sessions. Or D, to allow for silence. I have an A. Why do counselors use reflection in sessions? And the answer is A. To help clients understand underlying emotions. And many times we're reflecting back, so it sounds like you're feeling like. So many times our clients really just don't have the words for those. Okay. Number four, Carl Rogers. Okay. Carl Rogers believes 3 core conditions must exist for effective counseling. And this is a pretty common one you'll see on the test. Okay. So is it trust, empathy, and kindness? B, empathy, positive regard, and kindness. C, genuineness, trust, and congruence. D, empathy, positive regard, and congruence. What do you think those are? A, B, C, or D? Okay, it is D, not C. Trust is not one of them. Empathy, positive regard, congruence. You might see non-judgmental attitude, but trust is not one of Carl Rogers' words. I think what he hopes is that the client will trust us. However, the core conditions come from the counselor for what we're portraying, what we want our clients to see in us, and trust is not one of those words. Okay. Number 5, positive interactions help develop the therapeutic relationship and encourage clients to meet their goals. What are the 4 stages of positive interactions in counseling? 4 stages. A, exploration, consolidation, planning, and treatment. B, initiation, clarification, structure, and relationship. C, initiation, consolidation, planning, and termination. D, exploration, clarification, planning, and relationship. What are it? A, B, C, or D? Okay, I see some D's, B's. No. 6 is B. Very good. Initiation, clarification, structure, and relationship. Exactly. That's the process we're going to go through. Client-counselor relationship. Good, good, guys. When does negative transfer occur? Okay. So 7. A, when counselors project feelings onto clients. B, when clients project feelings toward another person in the past onto the counselor. C, when multiple roles exist between a therapist and a client. Or D, when clients become angry, hostile toward counselors. Okay, so A, B, C, or D. That is D. Okay, 7 is D. Negative consequences. Let's try to read that. Negative consequence can result when clients become angry and hostile toward the counselor. Although transference is an essential part of the psychodynamic counseling, negative transference can be difficult to manage and must be dealt with in the therapeutic process. So that is negative, okay? So what does that mean? Could someone give me an example of negative transference? So that was a trick question. I would agree. Okay, but so transference, and because it's negative, because Freud always says it's good, it's either good or bad. It just is. However, when my transference is maybe bringing on things that, you remind me of my mom, and I didn't like my mom, then that can bring up some negative feelings. So I can say some choice words or things like that because you act just like my mom. So that would be a negative. That's something that would just be dealt with in therapy. Like, I'm sorry, little Johnny, I certainly hear where you're going, but I'm not your mother, and etc. So you just deal with it. Okay. The next one is the 4 phases. Oops, there we go. The 4 phases of crisis as defined by Gerald Kaplan. Okay. Is it A, threat, escalation, resolution, follow-up? B, threat, intervention, climax, resolution? C, threat, rapport, strategy, treatment? Or D, threat, escalation, acute crisis, or climax? A, B, C, or D? Number 9. I see a B, A. That one is D. That's the correct order. Threat, escalation, acute crisis, and then climax. There was a threat, then it escalated, then the crisis happened, and then after it climaxed, it just came back down. Okay. 10 is those 7 stages, the 7 stages of crisis intervention. Okay. And again, this came about after 9/11. So A, assessments, identifying problems and referring out. B, establishing contact, providing counseling, and then referring out. C, assessment, establishing rapport, and identifying the cause of the crisis. or D, intervention, assessment, and treatment. So what is the correct order for those? A, B, C, or D? I see a B. Come on, be brave. The answer is, come on, come on. A, a D. It's C. It's C. Assessment, establishing rapport, and identifying their cause. So that's my little triangle. And again, I like the visual of it. So that's a triangle. Okay. 7 stages. Okay. Robert's 7 stages. So, okay. And I think that just for, again, for some of us, it's a little more difficult to remember because we don't normally treat it this way. And this was not made by someone in the mental health field. It was come up with some crisis intervention people. So this is kind of the model we've adopted and we follow. So for us, it's a little bit different, I think. Okay. Number 11, the CISD is short-term work done in small groups and not considered psychotherapy. Techniques used include processing, diffusing, ventilating, validation through thoughts, experiences, feelings, and emotions. CISD is designed to work with which of the following? Crisis incident stress debriefing. Is that my A, my primary trauma victims, my B, human resource professionals, C, first responders, or D, secondary trauma victims? Come on, A, B, C, or D. Be brave, be brave. Got some C's, some C's, some C's. The answer to 11 is D. Okay. So secondary trauma victims, okay? And most people think it is for that, but you're actually treating people then who have come for secondary trauma. Critical incident stress debriefing is the most effective tool offered within 24 to 72 hours of the event. It can be provided to any trauma, it can be provided by any trained individual, including HR or mental health professionals, and is intended for groups with secondary trauma actions. So someone tell me, who are my secondary trauma victims? Witnesses, okay. You got it. Okay, and it's not that it cannot be used for first responders, because it can be. However, it was designed for the secondary trauma victims. Okay, it's critical incident stress debriefing. Okay, and again, I think I probably answered that one already. Number 12, when is it most effective? Yes, within 24 to 72 hours after the incident. You got it. Good job, guys. Good job. Okay, I got this before. Dabda. What's the correct one? How did I go? It is denial, anger, bargaining, depression, acceptance. Dabda. B. Good job. Good job. Dabda. Okay. How does instrumental giving different from intuitive giving? Huh. Intuitive instrument is thinking, intuitive is feeling, instrumental is action oriented, intuitive passive, instrumental is more feminine, intuitive more masculine, instrumental is anger, intuitive is acceptance. A, B, C, or D, which is that? Okay, instrumental as opposed to intuitive. Okay, that is A. 14 is A. Instrumental is thinking, and intuitive is feeling. Okay, and you might not know what instrumental is. That's purposeful kind of thinking about it, but most of us know that intuitive, that word is our feeling. We've got our intuitions. Okay, and that's an example of how to answer the question when you're not really sure. If you didn't know what instrumental meant, we kind of know that my intuition is. Okay. 15. Guidance counselors may feel there's a certain situation when it becomes necessary to make referrals for clients to seek other counselors, also known as referring out. Which of the following is not a reason for counselors to refer out? A, the client issues outside the counselor's scope of practice. B, dislike for the client. C, client's need for specialized services. Or D, the counselor retiring or may take a leave of practice. When is it not okay to refer out, guys? B, exactly. We don't like that client. And I know none of you have had that, but many of us have a time where we really just don't like the client. We have to work really, really hard to find the strengths in that client. Okay, I'm going to send you this one with the answers for your homework assignment there. I'm going to do a little more. I'm going to do some of the pocket prep. If you're familiar with those and you know all the answers, then, don't chime in. And again, it's important to kind of look at different sources and not only just the information, but how the questions are written. It helps us really generalize the information. Okay. And what I always recommend is when you're studying is you kind of study the area that you're working on. If it's right before the test, of course, then study everything. But if it's just the areas that you're working on, then you kind of you kind of narrow it down. Okay. So we're talking about the helping relationships today. So I'm going to go on and narrow it down. Okay. So I'm going to take out this one and let's see here. We did that one last week, so I think I'll leave it in. Okay, so we're going to study all three of those sections today. Okay, I need some answers here, guys. When sharing her moral beliefs with her counselor, a client states that she believes there are universal ethical principles, but she wouldn't be afraid to go against these principles in the name of human rights, such as justice or liberty. What stage of Kohlberg's moral development is the client in? A, B, C, or D? Be brave, be brave. C. She's in post-conventional. That was a bad one, my fault. But yes, she's in post-conventional. That is C. Good job. Good job. A school-aged child is a member of several systems: family, social, neighborhood, and peers. Who would argue that it's important to examine all systems impacting this child? The question is who? And I don't know if you know who this belongs to. Guesses? A, B, C, or D? And even if you don't know, rule out. Okay, so D, Bandura, he did my social learning theory. Levinson, he did the men. Perry is my college guy. Okay, so it brings down to A. That's Bromfenbrenner. Okay, and if you're not familiar with them, He talked about meso, micro, and all those wonderful things. Okay. It was Bronfenbrenner. Okay. He believed that our microsystem was our immediate environment, our mesosystems, our connections, exo and macro. Okay. And then our chronosome systems. So those are Bronfenbrenner, his ecological systems approach. And again, our micro was just us. And then our meso, sometimes it's a Z, M-E-Z-O or M-E-S-O. And then our exosystem, macrosystem, chronosome system. Again, so those are definitely from Bronfenbrenner. I forgot to put those in the chat box there. Oops. Okay, what I did just put in there, I didn't mean to put in there, I was going to tell you later. That's a really cool game. It's an NCE game that's really fun to play. So it kind of helps you a different way of learning. That is what I just put in there. So I need to copy this one. It just won't copy. Okay. That's a video from Bronfenbrenner and how that works. Okay. Free association and dream interpretation are techniques that would most likely be used by a counselor who believes in which major counseling theory? A, self-psychology, B, object relations theory, C, psychoanalytic theory, or D, individual counseling. Okay. I see some C's, I see some C's, and you are right. You're absolutely right. That's my psychoanalytic theory. Perfect, perfect. According to object relations theory, normal progression through 4 broad stages during the first 3 years of life is necessary for healthy functioning. All of the following disorders except which one may occur if the normal progression does not take place? So it's an except question. So 3 of these things will happen and 1 will not. What do you think? And according to object relations theory, that belongs to Margaret Mailer, if you're not sure about that. Her name is Margaret Mailer. Okay. That is her theory. Okay, back to the question. Okay, what are my answers? A. Bingo. Good, good. Here we go. Child is 17. Recently dropped out of school and living at home. He does not have a job, even though he sometimes goes with his mother to the animal shelter to volunteer. When a family counselor asks the boy what his career and education goals are, he shrugs his shoulders, walks while his mom jumps in to explain that he wants to be a police officer, but he's just taking a break. When asked about the boy's responsibilities around the house, the boy's father rolls his eyes and tells the counselor that his wife does everything for their child, including making his meals. The mother tells the counselor that she and her son have a special interest and they seemed pleased when they say the father is not a part of it. The mother and the son are experiencing what? What is that? I hear a C, an enmeshment. Ah, yeah, yes. Enmeshment. You got it. You got it. So enmeshed families are just way too close and very unhealthy. And then this disengage or the opposite side, where there's no engagement whatsoever. This family also, whether or not arguing, this is definitely a triangulation. Okay, so mom and dad, or I'm sorry, a subsystem. It's a triangle subsystem because mom and dad should be the subsystem, not mom and kid. So there's some triangulation going on there. Okay, mom and dad should be the subsystem, children are our own separate subsystem. Okay, next. A married couple with two school-aged children gets divorced which drastically reduces the amount of conflict in the home. All of a sudden, however, the younger child starts throwing temper tantrums, whereas he was perfectly well behaved. What phenomena might explain the child's exchange in behavior following the divorce? What was that about? Enmeshment, permeability, cybernetics, or homeostasis? What explains that one? I see some typing. A D, homeostasis. Okay, very good. You want to elaborate on that, Joyce?
Ma'am,
Do you want to elaborate on that?
I just guessed.
Well, you guessed right. Okay, so homeostasis is the point of what we're used to, our normal routine. Okay, so if my normal routine is to come home from work and make dinner and do whatever I need to do, that's my normal routine. That's homeostasis. So they have two children, they get divorced, and drastically reduces the amount of conflict in a home. Let me just show the explanation about that. I apologize. Let's just let you read it. So homeostasis really is that routine, that normalness in the home. And sometimes it gets messed up. Things happen. Sometimes as a counselor, we have to mess up the homeostasis. If the homeostasis includes coming home every day and, beating the dog and, beating the wife and drinking, that's not a healthy homeostasis. So that's the routine they're used to. So sometimes we have to disrupt that. Okay. Okay, a counselor is conducting diagnostic sessions with a family and wants to learn more about the family's dynamics, unspoken rules, and communication patterns. Which of the following will be the best tool for the counselor to use? Would I use an eco-map, open systems? Would I use a strategic approach or a genogram? I'm looking at the unspoken rules. I see D, a genogram, family dynamics. A D, a genogram? Genogram. That's from Murray Bowen. He talks about the multi-generational families. I think most of you had to do probably genogram back in many years ago when you were in college, right? They were pretty common. Okay. Which of the following helps to maintain homeostasis within a family system? Again, homeostasis is that normal kind of equilibrium keeping us safe. The B, equal finality, that is a term that means we get to the finish. We may get there different ways, but we all get to the finish line. So equal finality is that term. Okay, do I see some guesses? A, B, C, or D? Sure. Okay. So, which of the following helps to maintain homeostasis in the environment? Maritza, can you tell me what you picked yesterday and what you were thinking?
I want to say I picked, I think it was like positive feedback loop, I think, or I don't remember which one I chose. I have to look back and look, but I want to say it was either A or C that I chose, and I was looking at A because I mean obviously it's like the dependence, right, and homeostasis, and the way we act, or it had to do with the following question, I think. But yeah, I think it was, for me, is the total guess, just kind of trying to think of what the terms were, to be honest with you.
Okay. So the question is, which of the following helps maintain homeostasis within a family system? Okay. So negative feedback loops. Positive feedback loops are patterns of interaction that can facilitate change. Equifinity is the name of that. So negative feedback loops are patterns of interaction that maintain stability and homeostasis within the family. Let me give you an example of that. I want that. Okay, just in general about feedback loops. Oh, no. Okay. So feedback loop is a part of a system. This is a systems theory in which some portion or the system's output is used for input for future operations. Each feedback loop has a minimum of 4 stages. During the first stage, input is created. The second stage, input is captured. Third stage, input is analyzed, and the insight then is used to make the decisions. Okay, negative feedback loops are self-regulating and can be useful in maintaining the optimal state with specific boundaries. Okay, so an old-fashioned house thermostat that uses the bang control. So this is to control the furnace. When the temperature drops to a predetermined low cell, the thermostat switches the heating system on. When the temperature sets its predetermined heat, it goes off. Okay, so negative feedback loops are known for being stable, but not always accurate. For example, in the case of the home thermostat, there can be a fairly wide range of acceptance materials. So the negative feedback loop kind of is the feedback comes out and it goes around the input, it comes back in. That's kind of what it looks like. Okay.
So would that be considered a good thing?
It would be. It would be.
Okay.
Okay. So remember also in the family systems, negative entropy is a good thing. Okay. So here is my system, and then my input, and then positive, I'm getting some positive feedback. Negative, I'm getting some negative feedback in my system. Okay. So negative feedback is going to allow me to or maintain homeostasis within my system. I'll give you another example. It's a systems approach. So, our systems approach has kind of worked with systems before we brought them to families. Yeah, it is a little confusing. Let's work on that one. Hello? Sorry, someone just came in my house. Let me go back. Okay. So again, it comes from the theory of, the systems theory and how it takes this system to work. Okay. So example of the negative feedback loop. So for example, then I'm shivering, I'm cold. Okay. So then my body temperature decreases. That's my negative. Oh, I'm cold. My body and temperature increases. Oh, as I get increase, that's a positive feedback. And then I begin to cool down again because I've got the feedback. Okay, so it's a kind of, I get the feedback, therefore I know what to do. I know how to act. Okay, so positive feedback involves a response that reinforces the change detected. So there's a change detected, and I'm going to respond to that. That's my positive feedback. Here's my negative feedback. That's positive again. Go negative.
So would this be kind of similar to like the way things are responded to in a sense?
It is.
Okay.
So the feedback you get, if I'm going to get negative feedback, then I'm going to continue to make a change. So however that flow works, then I'm going to take it back to to be homeostatic. I'm so used to my regular routine. I come home and I make dinner every day, and then I come home and I get that from some negative feedback would be, wow, I'm hungry, Mom. What's going on? We're getting some kind of negative feedback. So in order for me to if I stop cooking dinner, so then I would hear that negative feedback and I'd go back to what I was doing to maintain the homeostasis. Because the question is, what works best to maintain the normalcy in our house? So that negative feedback loop helps contain that normalcy in my house. Whether it's good or bad, that's kind of what we've been doing.
So, I mean, the way I'm kind of trying, maybe I don't know if I'm the only
Oh,
one
it's
that's
difficult. I get,
getting wrong, but the way I'm thinking, okay, positive is like where you want to be at. So the negative would be like you're reinforcing to try to get back to that positive. Is that kind of correct?
It's just homeostatic, so it's just where you were.
Okay.
Okay, so all you're trying to do is stay where you were. So in this question, the one that helps it to maintain it is being negative feedback.
Okay.
Go ahead. Okay, so positive feedback would help. We might make some changes if we did it that way. The negative feedback is not allowing me to make any changes because it's the homeostasis is working for us right now. So why would I make any changes? I'm going to send you, there's a really good YouTube video on that one.
So in your scenario, when you were talking about if your kids came home hungry and you continued to make dinner to kind of make the balance for the homeostatic, would on the positive loop be if they came home and said, you continued to make dinner and they came home and said, no, we'll just grab a sandwich or we're not hungry? Is that the
Or
positive, or is it
yes,
still
or they
negative?
yes, they no. If they come home and they're like, "Oh, mom didn't make dinner anymore. Let's do something different. Let's make dinner ourselves."
So change is made then.
That change is made. Okay, the negative, I'm not going to make any changes. And the goal of in homeostasis, I want to stay where I'm at. Okay, so homeostasis is not good or bad. It just is what it is. So sometimes I want to change homeostatic. If I come home and the family situation is healthy, I need to change that. So then I might give, we might work in a positive feedback loop. But if I'm just trying to keep it where it is, it's a negative feedback loop.
Okay, I think I'm starting to get it.
Okay, I'm going to just, and again, it's a systems approach. So to find how it works with families is a little difficult sometimes. So, we base that on systems. Let's see if I can find one on families. Here we go. I'll just put that in the chat box. Okay. It talks about why homeostasis is so hard to change. Okay. So the homeostasis is not good or bad, it just is. So some families that are the homeostasis in their family is fine, but other families it is not. Okay. Okay. Next one. In 1976, Gal Sheehy wrote Passages, Predictable Crisis of Adult Life. What is one of the main points of this work? A, B, C, or D? Remember, this is different than Levinson, who wrote about men. B, B. Got it. My B. Okay. It is common for anxiety disorders and attention deficit hyperactivity disorder to occur in the same individual at the same time. This phenomena is, if you get two things happening at the same time, what is that? A, B, C, or D? Got it. That's comorbidity. When a counselor is conducting a mental status exam, he notes that his client smiles appropriately throughout the session and tells the therapist that he has been feeling more peaceful and happy over the past several weeks. The counselor is assessing the client's what in his MSE exam? A, B, C, or D? We got it. Mood and effect. Generation X, between 1965 and 1976. Which of the following characterizes this group? I'm a Gen X. Anybody else in this group?
Want exciting, goal-oriented, and civic-minded.
We are C. We want exciting jobs. Okay, we are C. Does everybody know those generations? The baby boomers, generation A, B, C, and D, or not A, B, C, X, Y, all those? I've seen a couple of those, just in general, so you know. Okay, just in case you're not sure where you're born at, what generation you're in. Does anybody know what they're considered to be in? That's some Gen X's. I've seen 74 and 79. So that one says 79. I've seen 74 and 79. So I guess you get to pick on where you're at. So I've also seen like the baby boomers, some say 65, some say not till 66. So you get to pick. Okay. Marriage rates in America have declined over the past few decades. All of the following are reasons for the decline, except what? So this is one of those except questions. So what is one of the reasons that's not a reason for decline?
Let's see.
Got some C's. There you go. It's my C. It's my C. Okay, so we're going to wrap it up, guys, today. And there will not be a session next week. I'll actually be out of town. There'll be one the week after, but not one for next week. And I'll post up what it's going to be. I'm pretty sure we're going to probably do research the following week. That'll be the 25th, 24th of October. Okay. Questions on today? Did you learn some things that you hadn't been aware of, or was just a review?
Yes.
Okay. Hope you learned a lot. And again, this one should be videotaped. Hopefully it is. And last week I sent you the one the day after. So if I do different things, different material, I will send you both of them also, so you have both copies of those. Okay. I'm also send you a copy of the questions we work on today. We didn't finish all of those, so you'll get some of those answers. Okay. Anything else I can send you? See where it's a typing. Haha, I can give you lots of prayers. That is definitely for sure. That is for sure. Thank you, thank you, thank you, thank you, thank you. I actually do public speaking, and I was in a relationship for 25 years where it wasn't physically violent, but definitely he was very emotionally controlling. So I'm doing a conference, a domestic violence conference this weekend where I'm the guest speaker. So that is where I will be. So yeah. So I will see you guys the weekend after. If I see you, I don't know if it'll be recorded, Maritza, but I'll send you a link. I have a couple of times where I've recorded it, so I'll definitely can send you a link. I have a I have a YouTube channel. There might be something on there. If not, I'll make sure I'll send you guys one. Not a problem. So again, if I have sessions with you this week, or if you want an individual one, and Maritza, I'll get you in on Friday of next week. I do apologize. So if you want an individual session this week, just give me a holler through Skype or email. If not, I'll just see you the following Saturday. And again, if you have any questions during the week while you're studying, a question comes up, feel free, give me a text, give me an email, and I'll gladly get you through it. Okay? You guys are world changers, and I thank you so much for being amazing world changers. I'll see you. Bye, guys.